eNormous nephrology. This talk will be on the polyuria of solute diuresis. Frequently in the nephrology setting and in any clinical setting, patients can sometimes make a ton of urine. And if it's more than 3 liters of urine output, technically that fits the definition of polyuria. What is the cause of the polyuria and how do you treat it can sometimes be baffling. And if you don't treat it correctly and academically, then it can become very confusing. So I'll begin with a case report because my philosophy is that if you nestle facts within a case story, then the facts are retained for longer and are retained in a usable form. Otherwise, the facts remain facts and easily forgettable and also not easily integrated into the clinical scenario, into the clinical practice. So we have a nephrology consult. The reason for the consult is polyuria. The patient is making a urine output of 300 cc's per hour. So we'll go to the patient case. The chief complaint of the patient when she was admitted to the intensive care unit was nausea and fatigue times 1 week. Patient is a 35-year-old female with past medical history of juvenile rheumatoid arthritis, treated with as-needed NSAIDs, who presents to the University of Arizona Medical Center with complaints of 1 week of nausea and fatigue. It all started 1 week ago when she traveled from Michigan to Arizona. Nausea has been progressive with unrelenting retching, but no vomiting. She feels malaise, fatigue, and diffuse body pain and feels sleepy all day. She has had persistent fevers. During hospitalization, she developed headaches, nuchal rigidity, photophobia, and encephalopathy. So review of systems is not significant for travel, any visitors from outside of the US. She's fully vaccinated, no sick contacts. This is not typical of her rheumatoid flares, and mother and brother have had similar sicknesses in the recent past. So she was febrile, and essentially it became a fever of unknown origin because the cause of the fevers was not really apparent. It didn't seem like a rheumatoid flare, and so blood cultures were negative, TB workup was negative, Coxsackie A, B1, B2, B3, B4, B5, B6, all negative, Q fever was negative, VDRL, VZV, herpes simplex, all negative. The ANA was 1 to 160. The reflex for the ANA was not really significant. C ANCA and P ANCA were negative, and double-stranded DNA was negative, complements were normal, and rheumatoid factor was negative. Because of the nuchal rigidity, a lumbar puncture was done, and basically it showed low glucose, high total protein, high white count, and mildly high neutrophils, which could potentially be consistent with bacterial meningitis. But the CSF cultures, which were drawn prior to the antibiotics, were negative. So potentially could still be viral meningitis. But basically they threw every antibiotic they knew at her: vancomycin, ceftriaxone, acyclovir, fluconazole, ampicillin, doxycycline, and Bactrim. Fevers persisted, and because of concerns for sepsis, patient was given normal saline, and subsequently polyuria ensued. And so the normal saline was increased to match the urine output, and the urine output kept increasing. The normal saline was successively increased, and then the polyuria was too much, and the persistent polyuria could not be matched by normal saline, leading to a nephrology consult. So what is the differential diagnosis? Anytime you think about polyuria, you should think about water diuresis versus solute diuresis. And this pretty much means that either there's a solute that's driving the diuresis, typically sodium or glucose or urea, sometimes other solutes like mannitol, or it's a water diuresis, which is independent of solute. Typically things like polydipsia if in the outpatient setting, or diabetes insipidus. And if you have a combination of water and solute diuresis, then you have a mixed diuresis. And usually it's either a major solute diuresis or a major water diuresis with a small component of the other. So there is a mixed picture in the usual clinical setting. So water diuresis, and this talk is obviously about solute diuresis. So water diuresis will be briefly mentioned. This is not a talk on water diuresis. So obviously excessive water intake will lead to a water diuresis. Water intake can be iatrogenic, psychogenic polydipsia, if you have a defect in the thirst center. And some studies have shown that angiotensin II stimulates water intake. And then of course diabetes insipidus, whether it's central, nephrogenic, or due to excessive vasopressinase. So let's talk about solute diuresis. The major solute that drives polyuria is the sodium-driven solute diuresis, or in this case, electrolyte diuresis. And as we will find out later on, you can divide solute diuresis into electrolyte diuresis and non-electrolyte diuresis. The electrolytes mainly being sodium, and that can be because of sodium chloride load, whether it's salt consumption or enteral or parenteral. And then sodium wasting can cause solute diuresis. Loop diuretics, Barter's syndrome. Bicarbonate can be a source of polyuria in some cases, whether it's bicarbonate loading or inhibition of carbonic anhydrase. And then diabetic ketoacidosis. The non-electrolytes would be glucose and urea. And in terms of urea, the main clinical scenarios that we think about when you think about urea is acute tubular necrosis, in which you have a buildup of urea in the form of BUN. Post-obstructive diuresis, where you also have urea buildup, and other solutes as well in the tubules, leading to a post-obstructive diuresis. Exogenous urea loading, as in TPN, or amino acid loading, hypercatabolic states. Rhabdomyolysis is a urea-driven, can lead to a urea-driven polyuria, or massive hematoma reabsorption or GI bleed, and then miscellaneous causes such as mannitol and glycerol. So we'll go on to the labs. The main ones to see here is that the sodium is kind of high normal. So the polyuria has led to kind of a prerenal state. Potassium isn't really low at this point, so the polyuria has not really stimulated potassium excretion at this point. Chloride is high. Bicarbonate is 24, so it doesn't seem like it's a bicarbonate diuresis. BUN is only 5, so it doesn't seem like a urea diuresis. But at this point, this is all, it seems like this or it doesn't seem like this. We haven't proven anything. In polyuria, you should prove it. And you should get into the habit of proving it, because in nephrology, a lot of assumptions are made. Like, oh, this patient had acute tubular necrosis due to NSAIDs. You don't actually do a kidney biopsy to prove it. But in polyuria, you can prove it. And you should prove it, because if you don't know what you're dealing with and you're treating it in a way that ultimately confuses the whole picture, then you don't know how to modify your treatment and how to reach your goal of eliminating polyuria. Glucose is 119. Again, it doesn't seem like a glucose-driven polyuria. And CPK is only 352. Aldolose is 6.2. Miscellaneous labs, cortisol is 15, and A1C is 5.3. pregnancy test was negative, and TSH is 0.69. So urinalysis, specific gravity is 1.005, range is 1.005 to 1.03, and usually in a water diuresis you would expect it to be less than 1.01. Now the good stuff. So the serum osmolality is 288, and then another level check later on was 293. Urine osmolality was 292, and subsequently 290. These are just the times at which they were recorded. I've just put them in here just to show you that this is a real case, and this is not a made-up case. So what we would notice here is that the urine osmolality is almost the same as the serum osmolality. So basically it's almost a isostenoric state. And then we'll talk about later what that means when urine osmolality actually approaches serum osmolality. Urine sodium is 118, urine potassium is 14.7, and urine output, as we said, is 300 cc's per hour. So now, the first thing is we have to know what polyuria is, because sometimes you're not dealing with polyuria. The patient might say he or she is making too much urine. The consulting team may say patient is making too much urine, but is it really polyuria? What is the definition of polyuria? And then we can talk about what is the cause of polyuria and how does one dissect the differential diagnosis. And then the last question would be, how does one treat the polyuria in this case? So a complaint of increased urine output is often based on the patient's experience of increased urinary frequency with or without increased urinary volume. And for us, it's the urine volume that matters. And polyuria is defined as more than 3 liters of urine per day. Polyuria may be the cause or result of polydipsia. Polyuria is significant. It disrupts sleep, disrupts activities of daily living, causes hypovolemia, rapid changes in serum sodium can occur, and dilatation of the renal collecting system, ureters, and bladder due to functional bladder outlet obstruction can result from increased urinary flow. So it's sometimes helpful to think about the renal site of the origin of polyuria. So if the GFR is high, if there's hyperfiltration, that can cause polyuria. So this is at the level of the glomerulus. In solute diuresis, it's typically occurring at the level of the proximal tubule or the loop of Henle because there is decrease in reabsorption of a solute. And water diuresis typically occurs at the distal nephron or collecting duct because you're losing water. So there are some formulas that you should know, but thankfully these formulas are actually quite intuitive, and because I do it so much, it almost becomes a force of habit. And even if you don't memorize it, you should easily keep them accessible so that you can look them up if you do have a case of polyuria and you're trying to explain what the cause of the polyuria is. So first thing to know is the electrolyte osmolar clearance, and actually we need to know the electrolyte-free water clearance, because obviously water diuresis would imply diuresis occurring without the effect of a solute or an electrolyte. So you want the electrolyte-free water clearance, which is the urine volume minus C-osm E, which is the urine sodium plus urine potassium times the volume over plasma sodium. Instead of memorizing two different equations, I just I put in the C-osm E into this equation here, and then I just remember the combined equation, which I won't do the math right now, but obviously it's easy to combine because there's a V in here and there's a V in here, so you would just do volume times 1 minus this fraction. The other is urine total solute. Urine total solute implies how much total solute content there is in the urine. And total solute would be the urine osmolality times the total volume. So that's actually easy, because all you need is a urine osmolality and the urine volume, and you can calculate the urine total solute. And then of that total solute, how much of it is electrolyte content? Then you can calculate the urine electrolyte solute, which is 2 times the urine sodium plus urine potassium times the total volume. And then once you calculate the electrolyte content, you can just subtract the electrolyte content from the solute content to give you the non-electrolyte solute content. So this way, you know how much solute there is, how much of it is electrolyte driven, and how much of it is non-electrolyte driven. And then you've already calculated the electrolyte-free water clearance, so you know how much of it is water driven. So the analysis of polyuria begins with urine osmolality. A water diuresis is typically urine osm less than 150 milliosms per kilogram. And a solute diuresis is a urine osmolality of greater than 300 milliosms per kilogram. Anything between 150 to 300 milliosms per kilogram would be a mixed water plus solute diuresis. In our case, if you remember, the urine osmolality was around 290. So it's kind of more towards the solute diuresis, but again, it's a mixed picture because it's between 150 to 300. I always have a systematic approach. I always do the electrolyte-free water clearance, and then I do the total solute content, electrolyte content, and non-electrolyte content. So here, I combined the formula for you. So the electrolyte-free water clearance is the volume of urine times the quantity 1 minus urine sodium plus urine potassium over plasma sodium. So if you plug in the numbers, urine sodium is 112, urine potassium is 14.7, plasma sodium at that point in time is 136. You get an electrolyte-free water clearance of 479 cc's. Clearly, if the patient is making 300 cc's per hour of urine, clearly this is a minor water diuresis. So at this point, it's already clear that this seems to be a solute diuresis. And the reason there is a minor water diuresis in this particular case is because any patient with solute diuresis will have medullary solute washout. All that solute, all that polyuria will wash out the interstitial medullary gradient, and you will essentially have an acquired nephrogenic diabetes insipidus. So let's talk about solute excretion. An individual's dietary solute is influenced by culture, ethnicity, and habit. In the healthy American diet, total solute excretion varies from 500 to 1,000 milliosms per day. Not all solutes are made alike. Alcohol is readily absorbed by the renal tubule, and the concentration difference for ethanol between plasma and urine is small, so alcohol will not cause a solute diuresis. That's the threshold that I use, and that's the threshold that's, I think, validated in the literature. So let's talk about isostenuria. I think I mentioned that the urine osm was approaching the serum osmolality. And the reason for that is that as a consequence of solute diuresis, the concentrating and diluting abilities of the kidney are compromised. The initial urine osm is high, but as you have persistent polyuria, then the urine osm will change towards isotonicity. And that's the reason why we have isostenuria, because in this patient, the polyuria was kind of maintained for a significant period of time. Just to mention, occasionally a polyuric patient with near isotonic urine does not have pure solute diuresis. For example, a severely dehydrated patient with pure water diuresis may have 24-hour urine volume of 3 liters with a urine osm of 300 milliosms per kilogram. If they're making 3 liters of urine and the urine osm is 300 milliosms per kilogram, the urine total solute is 900 milliosms. That formula is easy to remember. You should never forget that. The total solute content is the urine osmolality times the urine volume. Again, all these calculations require random urines. You don't need a 24-hour urine collection. But if you want to be academic and have academic insight, then you can do a 24-hour urine collection, but it'll show you the same thing. So in this case, the urine total solute is 900 milliosms, which is not consistent with a solute diuresis. So this is a water diuresis. So mixed water solute diuresis can occur in several clinical settings. Iatrogenic water and solute loading would be an obvious cause. Chronic renal failure will have a mixed water solute diuresis. Relief of prolonged urinary tract obstruction will have water diuresis as well as the solute diuresis. If you treat diabetes insipidus with normal saline, you'll have a mixed water solute diuresis because the diabetes insipidus will give you a water diuresis, but then you're giving normal saline. So you may have a supranormal urinary total solute plus a hypotonic urine. So let's go back to our case. Serum osmolality was 293, urine osm was 290, urine output was almost 7.2 liters. So the urine total solute is 2088 milliosms, clearly a pure solute diuresis. So why should we do the math? Why don't we just assume this patient received normal saline? Let's just assume that it's a solute diuresis because the patient received normal saline. And then stop the normal saline and ta-da, you're done. But of course, the clinical picture is not always that crystal clear. In this case, we might have a patient with meningitis. Meningitis can cause cerebral salt wasting or diabetes insipidus. If we had assumed that the meningitis was causing a diabetes insipidus, we would be wrong, because in this case, we've already proven that this is a solute diuresis. So other clinical scenarios to remember that they might help you in dissecting the differential. The head trauma setting is usually central DI. If you have poor diabetes control, of course, you would think about glucosuria. Lithium, you would think about nephrogenic diabetes insipidus. Bladder outlet obstruction, you would think about post-obstructive diuresis. If you have hypercalcemia in the setting of malignancy, you would think about nephrogenic diabetes insipidus. And if you have polyuria, but you're not polyuric at night, you might think psychogenic polydipsia because you're not drinking water while you're sleeping. So then let's get back to solute diuresis. You have to think two broad categories: electrolyte diuresis versus non-electrolyte diuresis. So we begin with calculation of the electrolyte content of the urine, which is 2 times the urine sodium plus urine potassium times the urine volume. Anytime the urine electrolyte content is greater than 600 milliosms per day, that's consistent with electrolyte diuresis. So the total solute has to be greater than 1,000 milliosms. If the electrolyte content is greater than 600 milliosms, it's an electrolyte diuresis. And then the non-electrolyte content is just the total solute minus the electrolyte content. And the urine non-electrolyte content, if it's greater than 600 milliosms per day, then there is a non-electrolyte diuresis. And both the electrolyte content and non-electrolyte content can be elevated. So in our case, urine sodium was 112, urine potassium was 14.7, urine volume was 7 liters. So the electrolyte content was 1774, clearly an electrolyte diuresis. And the non-electrolyte content, therefore, is 256 milliosms. So non-electrolyte diuresis is not playing a role in this clinical scenario. So what lights are involved? Electrolyte diuresis is almost always driven by a sodium salt, whether it's intravenous saline, excessive salt ingestion, loop diuretics, or sodium wasting. Sometimes the urine anion gap can help. The urine anion gap is the urine sodium plus the urine potassium minus the urine chloride, or in other words, unmeasured anions minus unmeasured cations. A highly positive urine anion gap indicates anions other than chloride, and a highly negative urine anion gap indicates cations other than sodium or potassium. But change in both unmeasured anions and unmeasured cations may leave the anion gap unchanged. So in general, if the anion gap is greater than -50 but less than 70, it suggests excessive urinary chloride. Unfortunately, in our case, the urine chloride was not done, so we could not use the anion gap to confirm our findings. And if the urine pH is greater than 7.4, you should at least rule out bicarbonate associated diuresis. And if the urine pH is less than 6.4, it rules out bicarbonate as the cause of diuresis. Urine pH in this case was 7.0. So this is a schematic. So if you have a solute diuresis, you should determine the electrolyte content of the urine. If it's more than 600, it's an electrolyte diuresis. Then you can measure the urine anion gap. If it's less than 70, a chloride diuresis is probable. If it's greater than 70, it's probably driven by non-chloride anions. So in this case, you can do a 24-hour urine sodium chloride. You don't have to. It's kind of an academic issue at this point. But if the urine sodium is greater than 250 millimoles in the 24-hour urine collection, the sodium chloride diuresis is confirmed. If it's less than 250 millimoles, it's probably a non-sodium, non-potassium cation. Usually you'll have a urine pH. If it's greater than 7.4, bicarbonate diuresis is probable. You can do a 24-hour urine bicarbonate to confirm. If it's greater than 200 millimoles, it's a bicarbonate diuresis. If it's less than 200 millimoles, you should consider anions other than chloride and bicarbonate. If the pH is less than 7.4, bicarbonate is not a major solute, and you should check ketones on the dipstick. If it's really high, it's probably driven by keto anions. Otherwise, medications are sometimes the cause of polyuria. So as far as non-electrolytes are concerned, we're mainly concerned with glucose, urea, or mannitol. I'm just going to quickly talk about these three. In the diabetic ketoacidosis or hyperglycemic hyperosmolar syndromes, you might see glucose-associated polyuria. Typically, you can excrete around 833 millimoles per day, 150 grams per day of glucose. And if the urine osmolality is 300 to 500 milliosms per liter, 150 grams of glucose would obligate an additional 1.7 to 2.8 liters of urine. Not a severe polyuria, but if you normally make 2 liters of urine, then you would be making around 4 liters of urine. So urea, if you're on a high protein tube feed, or if you have relief of urinary tract obstruction, or recovery from acute tubular necrosis, you might see urea diuresis. 1 gram of catabolized protein makes 170 milligrams of urea, and a protein load of 70 grams in a 70 kilogram adult will generate 11.2 grams of urea, which is 400 millimoles. So if the urine osm is 300 to 500 milliosms per kilogram, this will obligate another 0.8 to 1.3 liters of urine. The math works out very well. You can do the math in detail on your own. This is just to demonstrate that polyuria does occur with these non-electrolytes. 1 liter of 20% mannitol has 1100 millimoles or 200 grams, and 1 gram per kilogram of mannitol in a 75 kilogram person, approximately 400 millimoles of mannitol will obligate 0.8 to 1.3 liters of urine. So now we're going to talk about non-electrolyte diuresis. So if the electrolyte content is less than 600 milliosms per 24 hour and the total solute content is high, then it will be a non-electrolyte diuresis. You can do a semi-quantitative urine glucose If it's 0 to 2 plus, then it's a non-glucose diuresis. You can measure 24-hour urine urea. If it's greater than 250 millimoles per liter, urea diuresis is confirmed. If it's less than 250 millimoles per liter, check for solute other than glucose or urea. If the glucose in the dipstick is high, then glucose diuresis is probable, and you can confirm with a 24-hour urine collection for glucose. If it's less than 250 millimoles per liter, check for presence of another solute. If it's greater than 250 millimoles per liter, glucose diuresis is confirmed. This is just to recapitulate on the anion gap. Generally, if it's highly negative, then it's driven by cation other than sodium or potassium. If it's moderately negative or moderately positive, it's a sodium chloride diuresis. And then if it's highly positive, then it's driven by an anion other than chloride. So basically, that's the analysis. I have here several cases. These are all real cases. So there are 3 patients, patient 1, patient 2, and patient 3. Patient 1 had 2 collections, and these both demonstrate different types of polyuria. So we'll quickly go through this, and you can see that you can use this approach and it actually makes sense. What I typically do is I confirm it's polyuria. So this patient is making 4.8 liters of urine per 24 hours. So then let's just check the electrolyte-free water clearance first. And that's down here. Electrolyte-free water clearance is 1.4 liters. Clearly not a significant water diuresis, right? So then you'll check the total solute content. Let me see if they have a urine osmolality. So urine osmolality is 321. So again, sounds like a solute diuresis. Urine total solute content, 1541. That confirms it's a solute diuresis. Calculate the urine electrolyte content, 960. This is a sodium chloride driven or electrolyte driven diuresis. Which electrolyte is it? First, we'll just calculate the non-electrolyte content, 581. Clearly not a major non-electrolyte diuresis. In this case, it's a 24-hour urine collection. You don't necessarily need a 24-hour urine collection, but the sodium content in the urine was 422, clearly elevated. So this is a sodium chloride diuresis. And what was the cause of this patient's polyuria? The patient was eating too much salt. So this is driven by salt consumption. So the patient stopped eating salt and his polyuria resolved. Several months later, the patient came back and said, I'm making lots of urine again. And polyuria was confirmed. This time he was making 5.9 liters of urine. So now what's driving the polyuria now? Is he eating too much salt again, or is it something else? Again, I always check the, well, let's begin with the urine osmolality. So urine osmolality is 157. So this is kind of a mixed diuresis, but closer to water diuresis. Electrolyte-free water clearance, 4.2 liters. So again, this is consistent with a water diuresis. But let's just rule out solute diuresis. Urine total solute content is 926, not greater than 1,000. So this is not a solute diuresis. Both the electrolyte content and the non-electrolyte content is not above 600. So this is a water diuresis. And basically what happened in this patient was that patient stopped eating salt, but then he started drinking excessive amounts of water. So the cause of the polyuria here was psychogenic polydipsia. And then we'll go to this patient number 2. Again, confirmed polyuria, it's 3.3 liters. So this is a polyuric patient. Urine osmolality, 370. It sounds like a solute diuresis. So let's just check the electrolyte-free water clearance. And this is 0.8 liters, not a major water diuresis. Urine total solute, 1221. This is a solute diuresis. Urine electrolyte content, 766. This is a sodium chloride diuresis. Non-electrolyte content 455. This is not a non-electrolyte diuresis. 24-hour urine sodium was 270. So this is a sodium chloride diuresis. Next slide. So patient 1 we talked about was initially salt and then subsequently water diuresis. Next slide. So this patient was a patient who was taking lithium. So you would think, oh, this patient must have a water diuresis. So again, it's easy to jump to conclusions, but you had to prove it. And we proved that this was a solute diuresis. So this patient was in a state of altered mental status and was not eating. So he was being given half normal saline, and that was the cause of the solute diuresis. So let's go back. So patient number 3, urine volume in this case was 2.7 liters. So let's just say it's 3 liters. It's close enough. We'll say this patient has polyuria. Urine osmolality 450. This is a solute diuresis. Let's just prove that it's not a water diuresis. 2 liters of water diuresis. So there is a significant amount of water diuresis in this patient, but it seems more towards solute diuresis. So this is kind of a mixed diuresis. Solute content 1215. So again confirms solute diuresis. Electrolyte content 205. This is not a electrolyte diuresis. Non-electrolyte content 1010. This is a non-electrolyte diuresis. So what non-electrolyte diuresis is it? We have a 24-hour urea here, and that is 365. So this is a urea diuresis. So this patient was a liver transplant patient, and after the liver transplant, he was getting hyperalimentation. So he was getting 140 grams per day of amino acids via central hyperalimentation and 70 grams per day of protein via enteral feedings. And that was the cause of the urea diuresis. So our case was a pure solute diuresis due to normal saline with a minor water diuresis due to acquired diabetes insipidus from medullary washout. Normal saline was discontinued and polyuria resolved. Thank you very much. See you next time.